that's the other huge topic of our group. We have been involved in microbiota and GvHD and outcome of transplantation since 2012 now. And could confirm also in multicenter approaches that microbiota damage is one of the major risk factors of GvHD. This is repeated in multiple trials, in multiple studies, also, of course, by the leading center of the Sloan Kettering Cancer Center in New York. But there are many questions left, which were discussed in the Microbiota Forum. So a major question is how do this microbiota contribute to damage? The most popular view in the moment is that microbiota produce protective metabolites such as short-chain fatty acids, and if you have microbiota damage by GvHD itself or by antibiotics, then you lose this protective metabolites, and this contributes to impaired immunoregulation, like defect T cell Treg production. This is will be shown by one talk from our group, where we combined microbiota analysis and metabolite analysis, and could show the very close interaction, and that the metabolites itself are prognostic. So the presence of short-chain fatty acids is associated with highly improved survival. These are all very early events, and therefore we all are thinking about microbiota modulation or treatment. But there are still several obstacles to successful treatment. There are some reports also on the meeting that we can treat about 1/3 of acute patients with acute steroid refractory GvHD only by transfer of microbiota from healthy donors, and can improve the outcome of GvHD, which is kind of a proof of evidence, but also suggests that microbiota modulation alone is not sufficient to cure the majority of patients. So again, we have to find out which patients have microbiota dependent GvHD, microbiota deficiency dependent GvHD, which patients might have different forms of GvHD. So that's one task. And the other task is, again, we are treating currently patients with GvHD and with microbiota deficiency very late in the course of disease. So the better option might be to do it preemptively or even prophylactically before we induce microbiota damage. But there is a major caveat in this context, because the patients after transplantation are going to be neutropenic, and neutropenic patients have a high risk of translocation of bacteria, and even bacteria from normal FMT products could translocate in this period. So we cannot use microbiota modulation directly by microbiota in the period of aplasia, and we have either to do it prior to transplantation until the beginning of neutropenia and restart it after engraftment, or we have to find new approaches of microbiota modulation which reduce the risk of bacterial translocation.